Thanks everyone for joining us for our grand round. I'm really delighted to be able to introduce Alicia and Goody, who are our guest speakers today from Barts. Is that correct? Am I right in saying that you're from?
Not quite, but we'll explain everything shortly.
You will explain. Sorry, there you go. You'll explain fully. But you're going to be presenting about the PoweringUP project, about reducing inequalities in pediatric healthcare. So I really appreciate you coming to share your work, which looks really inspirational from the website that I saw from WHAM. But I'll leave you to introduce your work properly. So thank you very much for joining us.
Thanks, Nabil, and thank you to everyone at the Evelina for having us as these guests, kind of basically invading your grand round. So my name is Goody Singh, and I'm a consultant paediatrician, and I'm delighted to be joined by Alicia Berman, who's a paediatric registrar. Now, we both, in some ways, are representing ourselves in some way, and today we're representing an organisation called WHAM, which is the Wellbeing and Health Action Movement. And we are going to tell you about a project called PoweringUP, which is, as you can see on the slide, what this is really all about. But I want you to stay tuned all the way through and right up until the end, because there is a moment when we need you to get involved and we need you to take part and step up. So this is a presentation and it is a grand round, but it is also really about you taking part in what we're doing today. So I'm going to hand over now to the lovely Alicia, who will take us through the presentation.
Thank you, Goody. So the aims by the end of our talk, we hope that you'll be better informed about health inequality. You'll understand the importance of listening to the voices of young people and learn how to engage in meaningful co-production. So to start off with, we thought we could use Slido. So if you could scan the QR code or input the hashtag number on slido.com, and then put any word that comes to mind when you hear the words health inequality, and we should start to see a word cloud forming. And we can give a few minutes for that. And if it's not working, please unmute yourself and tell us, because it's our first time using Slido.
There we go. This is, it certainly looks like there's like 20 people on this call, so there should be a few more words that pop up soon. Brilliant. Keep them coming.
Yeah, and if you've not seen word clouds before, like the more people who write the same word, the bigger the word comes up. So it looks like a lot of us feel that health inequality is unfair. And there's loads of great words coming through.
And just to say that your contribution to what we're doing today is really important to us. We want to be able to feed this back to the powers that be, and it's really interesting what you're saying. So please just write whatever comes into your head and what you're feeling right now.
I think there's one person still typing, so you can wait for them to finish. Okay, fabulous. Thanks, guys. So then, as all grand rounds, we'll start with a case. So this is a case about a 14-year-old girl who, and a bit about her problem. So she has this pain in her lower back, ribs and fingers. It's episodic and it's worse and associated with stiffness in the morning. She's been taking some simple analgesia regularly and gets minimal relief from it. At its worst, it's associated with some joint swelling, which can be so bad that she can struggle to hold a pen. There's no red flag symptoms, no weight loss, no night pain, no night sweats, no fever, no infectious symptoms. In terms of her past medical history, then there isn't really anything. There's a term baby, SPD, no concerns with growth development, no other health conditions. She's also not on any regular medications. She's up to date with her vaccines and doesn't have any drug allergies. There's a family history of IBD and atopy in her immediate family, and some autoimmune conditions in her extended family. Then a bit about her as a person. So she's a person of colour, English is her first language. She lives in a small commuter town and is of a middle class background. She lives in a house with her mum, dad, and younger brother, and she's got an older sister who's at uni. There's never been a social worker involved, and currently she's in year 10 at a state school and has her GCSE exams upcoming that academic year. She's very sporty as a person and part of lots of different teams and competes at a regional level, and nothing else came up in her heads assessment. So I wanted to take you through her patient journey. So it starts with her actually waiting 3 months before she goes to the GP, because she didn't want to trouble the GP because she in her head thought it was minor. It was pre-COVID, so she was seen by her GP in person, who then really assured her that these were normal menstrual cramps. So then 1 month later, her pain worsens and the paracetamol and ibuprofen aren't cutting it. She goes to her A&E at her local DGH, who she's seen by the ED team, and as part of investigations, they dip her urine, which was negative. She's then told she's got a UTI and given some antibiotics. Over that week, the pain worsens and becomes quite unbearable. This time, she goes to the tertiary hospital A&E, which is about 40 minutes drive away from her house. And there she's found to have low oxygen sats and was admitted for a coronary pulmonary embolism. Once the PE is excluded and her oxygen sats normalizes with good analgesia, but there's still no cause to be found. Her older sibling visits and is a medical student, and then asks the consultant on the ward round, could this be ankylosing spondylitis? The next day she's seen by the rheum team, and then she's discharged with rheumatology follow-up and further outpatient investigations. 10 months later, diagnosis of juvenile idiopathic arthritis is made. So she was under the rheumatology team there, but they felt that she needed more specialist care. So they set up shared care with a large tertiary hospital in London. And then eventually the London hospital takes over care because there were issues with the local hospital not being able to provide some of her medications, and some issues with organising investigations in a timely manner. So in this London hospital was about 90 minutes away from this young person's home by public transport. So then on the non-medical side, so initially she was having lots of time off school for the pain. And then because she didn't have a diagnosis, she didn't have a diagnosis to support her need to take that time off school. So that caused some issues with the school. And then even though she was under the rheumatology team, there was some time before she got the diagnosis of GIA, which meant it was that extra bit harder to get all the exam support she was needed, but then she did eventually get it. There were some difficulties with the shared care. So there were issues with letters not from each hospital not reaching the other, and not being able to see each other's investigation results. This was put onto the young person, who would then call the hospitals, get copies of the results and the letters, scan them in, and then share them with the other hospital. There was also issues in terms of them communicating, so the medications weren't being given on time, and investigations not being organised on a timely manner. And then as she found that she was having really good care at the London hospital, she decided that she would choose her universities based on the proximity to the hospital, as she sort of realised that she'll be having ongoing appointments and investigations with them. So going back to Slido, with this case in mind, do you think any of the following social determinants of health impacted her care?
And you can actually select more than one, I think. Is that right, Alicia?
Yes, I believe so. And it should have refreshed if you still got it up on your screen, I think. yeah, the responses are starting to come through. Yeah, so as you can see, look, there were lots of different social determinants of health that impacted her care. So I'll now hand over to Goody to tell us a little bit more about them and health inequality in general.
Great, thanks, Alicia. So I think for many of us, being a paediatrician in the 21st century can sometimes feel a little bit hopeless. And that's because we see upfront in our clinics that sometimes for some children, their lives are more limited by factors like their skin colour and their gender and their socioeconomic status than they are by the medical conditions, which, as you said in your word cloud, is unfair. So this is the social determinants of health at play. And these are the factors like where you're born, where you grow, where you work, where you live, that shape all of our daily lives. And the social determinants for our patients actually affect their ability to recover, their ability to access care, and even the quality of the care that is received. Social determinants are what leads to health inequalities. And health inequalities are the systematic differences in health outcomes between different groups of people. Next slide, Alicia. Now, in the UK right now, health inequalities are wide, and the sad part is that they are widening. We live in the 5th richest country in the world, and yet life expectancy differs by up to 20 years between the richest and poorest people. 4.2 million children are now living in poverty in the 5th richest country in the world. 2 million children go to bed hungry every single night. Now, as a result of all of this, our children are dying younger. They are growing shorter, and they're becoming sadder with each passing year. Next slide. The problem for us is that the biomedical model, which we all operate under within health systems, doesn't see the social determinants of health very well. The biomedical model is brilliant at seeing disease, but health inequalities are not caused by disease. They're caused by a lack of access to the basic ingredients for a good life. Now, this slide shows you what I felt as a registrar was happening, that kind of disconnect between what was actually happening in the lives of my patients and what I was actually able to offer them. Now, when health systems fail to see humans, us, in our total entirety, us as social beings, two things happen. One, we can actually fail as doctors to make things better for our patients. So we miss those opportunities to help our patients in materially significant ways. And two, we might even make things worse because despite our best intentions, health systems don't always operate in the best interests of our patients. And we know this because studies are telling us this. Black children are less likely to receive pain relief for the same conditions as white children. Girls are less likely to have their mental health taken seriously. And in our case, we heard that their physical symptoms were dismissed on account of them being a woman. And young people are regularly told off for not attending appointments that cost more than a decent meal to get to. What all of this is about is that if we leave the social determinants unattended, they are bad for our health. And by neglecting to address them, us, health systems, are making health inequality worse. Now, when you put it like this, health equity is a quality and a patient safety issue, and yet you wouldn't realise it by what's happening on the ground. And again, the Royal College of Physicians has looked into this issue, and 67% of nearly 1,000 clinicians that they surveyed had said that they had not received any training whatsoever in health inequalities in their education. Only 26% felt confident that they had any ability at all to reduce the impact of health inequalities on their patients, and only a third even felt that they could even broach the subject with their patients in clinic. Next slide. All of those reasons was why I wanted things to change. And I've done this with a small organisation called WHAM, the Wellbeing and Health Action Movement. Now, it is an educational and empowering organisation. I'm hoping that you will have heard of it before, but if not, then what you need to know about it was that it was started in 2021 by a group of paediatric trainees, like I was at the time, who were responding to health inequality in the wake of the COVID-19 pandemic. And what WHAM is a social incubator. We're basically a digital platform that enables the peer-to-peer sharing of the knowledge, the tools, and the community to inform, empower, and unite clinicians who wish to address the social determinants of health and health inequality in their clinical practice. We're basically making up for gaps in our own medical training. We've just heard how health is created by the social and economic and environmental conditions in which we live, but most investment occurs downstream in acute clinical services. So WHAM's goal is to help shift the attention of health systems and health policy towards those upstream determinants and to think about health much more holistically and equitably. And we're doing that by trying to change the health professional cultures, capabilities, and care delivered. And that basically means what we're all doing all of the time. Next slide, Alicia. Now, if you do, I think you need to click through a bit more. If you do have a look at our website, please explore all of the resources that we have. We have developed a whole suite of tools that will help you as ordinary clinicians to talk about the cost of living crisis, to signpost to local resources, and to even take action to change services yourself. Now, people have told us how helpful these resources are. And in fact, some of these resources are being used right where you are now in the Evelina and in the Mary Sheridan Community Paediatric Centre as we speak. So if you're interested in adopting and adapting these tools, then contact us later because that's exactly what they're for. I'm going to hand over back to Alicia now.
Okay, so I'm just going to go back to our case because we were in the fortunate position to hear from the young person and their perspective. So they recognised that they had certain privileges that other young people may not necessarily have. So firstly, that London Hospital was a transition specialist service. So there was no transition needed between a paediatric and adult service and didn't fall through the gaps that way. She also had a really proactive clinician there who provided holistic care, and she felt that she was listened to and her care was tailored to her needs, i.e. she was really, really sporty, and that was accounted for. She had engaged parents who advocated for her, and she had a family member who was medical who could translate those letters into simple language that she could understand. And she was also from a background where her parents could take time off work and they could afford the train fare to attend those appointments. On the flip side, she also recognised that some things didn't work so well. So she recognised that her journey could have been a bit smoother, and she felt that sometimes she's not always at the centre of her care and not always listened to. She disliked her letters containing jargon and words that she didn't understand and that they weren't always addressed to her. And she also disliked the logistical side of having to take quite a bit of time out of her day to attend these appointments, going back and forth, and how she had to be the one to facilitate the shared care rather than the two hospitals communicating with each other from her perspective. So what she does then is she voices these concerns to her clinician, who then listens to her and signposts her to different opportunities that she could be part of. She agrees to be part of a few projects that in hope to improve the healthcare for other young people and to encourage clinicians to listen to the voices of young people as well. But she also finds that there's differing levels of co-production amongst these projects. And at the more extreme end of the spectrum, she felt that sometimes she was there just to tick a box that there was a young person involved in the project, rather than her views actually being listened to. And sometimes she felt that her efforts weren't even acknowledged, that she was there. So going back to Goody, what is co-production and what was good co-production?
Great, thanks, Alicia. So we've just heard, haven't we, that health inequalities are one of the biggest challenges facing healthcare in the 21st century. And yet we've also heard that clinicians rarely talk about health inequality with their patients. And we've also talked about how it's a lack of training, time, and organisational support that means that we are missing out on opportunities to help our patients in meaningful and materially significant ways. And for us as paediatricians, the sad part is that one of the most neglected groups are young people. And we just heard that in our case, haven't we? Those aged between the age of 16 and 24 years are routinely overlooked in medicine. Now, clinicians often say that connecting with young people is really difficult. The problem is that adolescent DNA rates can be as high as 15%, and those rates are correlated very strongly with deprivation. All of this means that inequality and disengagement compound to mean that there's a delay of access to adolescent care. And as a result, young people experience some of the steepest health inequalities, which will negatively impact their health, not just now, but into adulthood, because this is what is happening, is that you're laying the ground for poor health right into the future. And young people are consistently reporting that the health services that we are providing do not meet their needs. Now, Alicia mentioned co-production as one thing that this young person tried to engage in. It is widely now touted in the NHS as a potential problem to some of the issues we've talked about. But what is co-production? So the definition I've put on the slide there is that co-production is involving patients in collaborating around the design of healthcare services, thinking about the policies with the aim of trying to improve outcomes and experiences for everybody who's involved. Next slide, Alicia. Now, not all of us have had the opportunity to take part in co-production, but for those of you who don't, the reasons that we talk about co-production at all is because there is potential benefits raised by it. Obviously, when you're tailoring services that meet the specific needs and preferences of different populations, we're looking to enhance the patient experience. Now, we know that involving patients in decision-making can improve their satisfaction and increase their sense of empowerment. We also know that this increases efficiency in services because it's obvious in a way, isn't it? If you understand what patients need and what their perspectives are, you can streamline services and reduce waste to make sure that we're putting our efforts where they are going to basically give the most bang for your buck. But they're also more effective. And that's because, again, they're based on real world experiences, not what we imagine patients need, but what they actually tell us that they want. And finally, and possibly most important, is stronger relationships. By collaborating with ordinary people in the community, we're actually building relationships between different groups, patients, healthcare providers, and potentially even policymakers. Now, healthcare at the moment is filled with projects that will tell you that they are doing co-production. But the truth is that doing co-production well is really hard. It takes time, it takes effort, and it takes care. And all three things are in short supply in the NHS at the moment. Next slide, Alicia. So this results in a number of problems because the co-production that then results basically fails its patients. And I'll tell you why. First, there's that issue of tokenism, which we heard about in our case. In some cases, patient involvement is tokenistic, where they literally are just ticking a box because it's co-production in name and not in genuine action. And so they're not really influencing the decision making. And that comes down to power imbalances. So there are power dynamics, obviously, between us as health professionals and our patients, and that can come in between us actually effectively collaborating. It means that we often influence decision-making, even with the best intentions, more than our patients. Now, there are also issues around resource constraints because, as we talked about, we're under huge limitations of funding and time and resources. And it means that actually how much of that can we invest to make sure that patients are involved properly? It can lead to superficial engagement. Another problem within the NHS, as anyone who's ever tried to change anything in the NHS will tell you, is the resistance to change. Now, healthcare systems are notorious for being slow to adopt any new changes, and co-production in particular, given what I've said about how differently it forces you to behave as a system. And the entrenched cultures and structures that we have in the NHS actually prevent us from adopting co-production effectively. And finally, limited accessibility. Now, the patient in our case was lucky because co-production was even something that was happening in their hospital. Not all patients have equal opportunities to participate in things like co-production or even to be heard by their clinicians in any meaningful way. And patients who are particularly marginalised and marginalised groups are the ones who face the biggest barriers. And you can imagine, right? Things like language, literacy, and socioeconomic status. So co-production overall is actually still relatively rare in the NHS. It's definitely growing. But what that means is that there are very few projects that have actually specifically looked at that intersection between young people and health inequality. And when we were performing a review of the literature on this, we found that there were very few resources, just a handful of resources, and they were of variable quality and variable relevance. And we realized that if we wanted to address health inequality in young people, we were going to have to learn how to do it ourselves. And that's exactly what we're doing. Next slide. WHAM is now seeking to improve our work on health inequalities with creative co-design. And the project that we're doing this through is PoweringUP. Now, PoweringUP is a Health Foundation funded pilot that is exploring the art and science of meaningful co-production in health. Now, what PoweringUP is trying to do is it wants to close the gap between where health services should be and where young people want them to be, right? So from young people being not seen, not heard, and not involved, we want young people and ordinary clinicians like you to be at the front and centre of radically reimagining health. Now, we're actually aiming to do that in a pilot that's stretching across Birmingham and London, and we've involved young people and clinicians, and the idea is that we're using creative methods to do that. We're using community-based approaches, and next slide. We've already achieved a lot in all of this. It's a creative process, remember, so we've already produced a lot of material. And next slide. The pilot that was going on in Birmingham was effectively a series of stepped engagement with young people in schools to train them up in science methodology so that they could become citizen scientists, go out into their communities and find out about the health problems that are affecting their families, and then present that at a really big event in Birmingham in front of health leaders, which was incredibly successful. Now, we were able to present that work at the National RCPCH conference just in March, and some of you will recognise some very familiar Evelina faces there, like Ronnie Chung and Camilla Kingdon, who have completely bought into what we're doing in PoweringUP. And they were thankfully getting into the pink that we're all wearing, which is our colour in our project, and supporting the values of this, which we think this project is more than just a project, right? We think it's a movement because what we're trying to do is show that healthcare can be done differently. Now, in addition to the cowboy hat and all of that, we've also produced tote bags, which you can see, supported by the new president of the RCPCH. We've also produced artwork. We've got an Instagram account, which you can follow, which we'll give you details to later. And we're going to be producing a zine or a digital repository that will have all of the tools that we're producing with young people, which will be available for clinicians like you and young people alike. We've also produced a film. Now, next slide, Alicia, which will give you a little bit of an overview of what this means, because a lot of clinicians, when they hear creative co-production, wonder what it is that we're doing. And given that we're going to ask you to get involved shortly, you might want to know what this is all about. If you want to read more about any of this, we've already written in Milestones magazine twice, so in the spring and the winter issues just gone. And there you will see a little bit more about how we are building this project and where we're at. So Alicia, if you could try and play that video now, it's just short, and I think it will give everyone a sense of what this is all about.
For me, this project is all about trying to make what I think is wrong with the health system better. And for me, the biggest problem in the health service is that the voices of people who need to be heard most are not being heard. And this project is all about giving voice to people who are normally neglected. Powering up means fighting health inequalities and really understanding what a health inequality is to different children, or even just anyone from different backgrounds facing different health challenges within the systems in place. I'm a junior doctor and work with lots of young people, and I'm getting a bit frustrated with the system and that young people aren't always heard. And also I have younger siblings who have gone through the system, and I'm not sure if they would have got the care that they received if they hadn't had a sibling who is a doctor. In some places, they're looked after by us, the paediatricians. In other places, they're looked after by adults, and their experiences that they get in these different places are very different. And the fact that it's so different everywhere in the country, I think that needs to change. I'm ready for a bit of reminisce. I had strong, determined, and revolution. We went into schools, and that was the big thing that we're teaching children to, why don't you want to come into the hospital? Like, why do you feel intimidated to come into an appointment? And
all of the connotations that are associated with having appointments. So Powering Up for me is about empowering the people that are within the system to speak up and actually fight against these barriers that are preventing them from getting the best possible care.
So focusing today a little bit on quickly blitzing some ideas for Powering Up to do some exciting creative stuff. What we've got today is a gathering of, I guess, a core group of people that are going to be forwarding the project and start really working on the project in a creative way and also like make things happen. Today we've been working on a magazine sort of template, we've been doing some filming, we've been doing some tote bags and just really sort of conceptualising what the project is going to look like with our main group, which is made up of people of all ages. We've got young people, we've got physicians, we've got public health influencers, we've got all sorts of people on board and that's really exciting. I see that our role as creatives is to amplify the child's voice, but also give them the skills maybe for young people to, you know, share their own stories and their own experiences and try and sort of make those connections of boosting confidence and boosting opportunity to be heard.
I want people to be heard because while I've been quite fortunate in the healthcare system, or at least with the doctors have, I've had problems with opticians in the past, which kind of fall under it. And I know other people experience many problems, so I just want them to actually listen.
Long waiting lists, people not understanding their issues, people believing that they don't have the issues because they're young, so they just ignore it. I feel like they are big problems, especially when it comes to schools and stuff and they don't know how to deal with them.
And I know it's not the hospitals, it's like the government's fault, really, in my opinion, because of the funding. They don't cut the funding, they don't support the healthcare workers, they pay them less, and it's the government. And if they invested in hospitals more than the healthcare workers, we won't be in this mess, and we'd have better health and being heard and stuff. So it's not the healthcare workers, it's not the whole, it's the government.
When I went to the doctors and it was a girl doctor and I spoke to her about my issue and she actually listened to me and I felt like I was listened to and that was really good. But that's not always the case.
The one thing I would change about the healthcare system is its philosophy, like the mentality behind it. Right now, it's really a sick system and it just cares about disease and what's wrong with you. And I think what we should be doing is focusing on health and well-being and how we can create those things together. And so instead of it being the doctor who fixes you, I want everyone to feel like they can take a role in making themselves healthy. So that's the one thing I would be doing.
We decided today what we would do is to do some tote bags. So we went into the print studio at the Art House. We've only just signed off on the logo for the project, which has been co-produced by various people in the group. Nobody had done screen printing before, so to actually be touching the materials, and they're very good here at the Art House at running sessions with the community anyway. So it was just that moment of reveal when the first tote bag came out and it had the Powering Up logo on it. Really giddy, I think, really.
I feel like the project's going to be a really fun one, mainly because there's so many different design elements we can bring into it.
Young people do know their own minds, and they also, you know, have a lot of intelligence about their symptoms and how they're feeling. And if they don't get that opportunity to be heard and to have that two-way conversation, something could be missed out. You know, they could be misdiagnosed, or the diagnosis might not be as thorough as maybe it could be.
It's going to be accounts from actual young people that have experience in this. It's not just going to be from what we think, it's from what we know.
Create something that they can't ignore and something that they're going to notice and something that they can't just brush over and something to get their attention.
They are the next generation of influences in our society, that there needs to be a shift in society, listening to the voice of young people.
I think a lot of people are really passionate about the cause. So actually, I hope that we have enough people fighting for our cause. So hopefully, you know, try and push some legislation or some sort of policy to improve the care and like the waiting times that people experience.
Great. Alicia, can you put us onto the next slide? So I hope what you have got a sense of is that Powering Up is a fun project. It is all about actually reinstilling hope into a system that otherwise often feels, like I said, hopeless. Now, we have one piece left of our project left, and there's still an opportunity for you guys to get involved, because it just so happens that Show Up, which is the second part of Powering Up, is taking place in South London, in Lambeth and Southwark. Now, Show Up is our attempt to try and think about how to creatively explore health inequalities faced by young people and the barriers that clinicians are facing in trying to provide good quality healthcare today. So what we're doing is we're setting up a series of theatre-based workshops with young people and clinicians in South London. And the idea is that they will co-produce a theatre production that will interweave clinicians and young people's experiences for a grand finale performance that will take place in early autumn, and will be done in front of your local healthcare leaders, your officials in public health, and possibly journalists and the media too. The idea is that we're going to try and kickstart a change so that local health services actually start meeting the needs of young people that they are meant to serve. Now, next slide, Alicia. Auditions are open, and by that I don't mean that you have to audition in the ordinary sense. What I mean is that this project is open to any of you guys who are working in the Evelina if you want to take part. All you have to do is scan that QR code, and it's a form, just literally a form to register your interest. We want all kinds of clinicians of all stripes. So if you're watching this and you happen to know that there's a nurse or a physiotherapist or an occupational therapist or even a porter that might actually want to take part in this, please share it with them, because we want the widest, most diverse group of people who are working in the NHS to be part of this show, because we know that everybody has a voice and a perspective on how health systems can change. It's taking part in a local school in Dunraven, and the 2 days that you need to have in mind, because you can ask for study leave now, and I know that there's enough time for you to ask for study leave, is the 18th and 19th of July. Those are the 2 days that you need, and all you need to bring with you on those days is yourself and your energy, and that's it. Now, you might be wondering, oh, I don't know, is this for me? I'm a junior doctor, like, why would I do anything like this? I'm going to let Alicia explain why this, or anything like this, or even Powering Up in its whole totality is a good idea. Alicia.
Yeah, thanks you for that. There's loads of reasons why you should be part of a Show Up. I guess like the first main one is that it's a really unique opportunity that you can work alongside young people to try and make some positive change on a wide scale level. It's also it's probably, yeah, you can tick off a lot of things from the Progress Plus curriculum by being part of Show Up, and what better way of doing it in something that's actually fun, and it's a bit different. We can do something creative and explore that side of yourself, and I guess you're going to be part of this new community of like-minded people, and who, if I say so myself, are pretty cool. And yeah, I think it'll be a lot of fun, so please do sign up.
So do you want to just round things off, Alicia?
Yeah.
And so then we can take questions, because probably people do have lots of questions. I'm sure you do. And you can grab us now to ask the questions that you got. But yeah, Alicia, do you want to just finish us off?
So yeah, so to summarize what we've talked about. So you've heard how health inequality is the biggest challenge that we as clinicians are facing in the 21st century. You've heard how important it is to listen to young people so we can successfully address health inequality. And we're all on this journey of learning how we can do this well. So thank you for listening. As Giddy said, we'll take any questions, and then these are the QR codes of various ways you can join us. So you can follow us on our PoweringUP Instagram, and there's a QR code for the WHAM website with amazing resources on there. and then the QR code to sign up for Show Up.
Brilliant, thanks, Alicia. Nabil, I guess you normally open this up now to questions, do you?
Yeah, we normally have a question and answer session now. So first of all, thank you for a really inspiring presentation. It was really interesting to read about all of that work that you're doing, and have such positivity as well in a space which feels quite deflating quite a lot of the time. I feel like I can speak for a lot of us here at the Evelina, where you feel like you're fighting a tide of ever worsening inequalities, deprivation. I work in nephrology myself, and just in the last 5 years, we feel like we're dealing with so much more of the social aspects of healthcare, and not just the more straightforward clinical side of things. And then just on the nephrology theme, there's been some good data to show that children of deprivation or social minorities, ethnic minorities, sorry, will have less access to living donor transplants than people from different postcodes or from white ethnic minority ethnicity. So there's lots of work to be done, I think, in all aspects of healthcare, including tertiary, primary care. So really, really important thing to tackle at grassroots levels, like what you're doing. And I would offer to audition, but I think I'd be pulled up for fitness to practice if anyone saw me dancing on the stage. So
No, you can't be pulled up for fitness to practice. In fact, the worse you dance, the better. Honestly.
Oh, okay, fine. It's one of those then, is it?
Please, I don't want anyone who's watching this to rule themselves out on account of thinking that they don't have the talent or they're not creative. Everybody is creative. Like, as pediatricians, we know this, right? We play all of the time. There is no single person who's watching this who could not take part. So even if you are even remotely thinking about being interested, just fill in the form. I promise you do not have to do anything that's going to make you feel embarrassed. More importantly, what we're doing is we're looking for a community of clinicians who can be supportive of the project, because it does require people on the ground to want to change things. And we're doing this project with the Evelina in mind, right? Because we want you, as the people who are working there, to have an influence on your own services. That's what real quality improvement is about and what co-production is about. So fill out the form and then think about all of the repercussions later. That's what I'd say. But Nabil, thank you for just actually putting into words and making real for people why this matters, no matter what specialty you're doing, no matter what kind of medicine you're doing, actually, whether it's pediatrics or not. These issues are really important right across the piece. And so that is why we exist, which is to turn something that is a very hopeless situation into something where we can feel like we can take action. So I hope that people have been motivated or inspired to do something today.
I was going to ask a question as well. Sorry, if anyone wants to ask a question, please put it in the chat screen or raise your hand, and then we can just direct yourselves. But I was going to ask about what kind of I'm thinking about things like other provisions that do you link in with. So, for example, youth workers and youth organisations. And I know we used to have Sure Start centres in a few of those, but thinking about those kind of early year support as well. Sure Start's really topical, isn't it? Because we've lost a lot of that provision. And I guess these are the gaps that you'll be trying to fill. But are you working across different areas as well?
Yeah, so that's an excellent question. So in case you were interested, this performance that we're going to be putting on in September, October, we genuinely want this to be a conversation starter, but amongst the people who actually can make decisions at that level. So we've talked about how health is not really just about the health service. It's about what's happening out in society. And as Nabila said, things like Sure Start, or the state of your schools, or the state of your housing, or where your food is coming from, and the price of foods is all important. But we don't have any power over that. People in the local authority have power over that. So people who are running the government have power over that. And so those are the people we're inviting to that performance. So that's who you will be performing to. That's who you will be speaking to directly to say, this is what it's like to be a doctor right now. And this is what my patients are suffering right now. And as Nabil correctly pointed out, what we're asking for is not really just like more doctors, more nurses, more beds. What we're actually saying is make sure our patients don't get sick in the first place, please. What we're actually saying is, if we know that there is an evidence-based intervention like Sure Start that shows that actually educational outcomes can improve in the poorest centiles of our population just simply by going to Sure Start, then why are we defunding it? why are we taking the money away? So it's all about trying to bring that kind of holistic, multi-sectoral view on health to life, actually. And actually, as doctors, being active in that and not just taking a step back and saying this is someone else's job, because actually we see the effects of it. And that's the problem, isn't it? We see the effects of it. And how can you look away once you've seen a child who's come in with rickets because of malnutrition in the UK? How can you look away and not say something about it?
And is this something that the Royal College of Pediatrics is right behind as well? It seems like there'll be a lot of overlap. I'm sorry, I don't know if that's a
no. It's a great question,
yeah,
and
because it sounds like the remit of the RCPCH as well to be advocating for this.
So, I mean, you like under Camilla Kingdon, the college moved a long way towards taking action on health inequalities in a way it hadn't done before. And so it's brilliant. We now have a health inequalities toolkit that the college is putting forward. But the college can't do everything, right? The college is limited. I mean, it is a charity and it's a royal organisation. So there's going to be limits to what it can say and what it can do. And that's why organisations like WHAM need to exist. We exist outside of all of that, and we can say what needs to be said, sometimes in ways that others couldn't. However, we're working together. Look, you saw Camilla Kingdon putting on the pink cowboy hat. Steve Turner's got the cowboy hat on. The college believes in what we're doing and they're supportive of what we're doing, which is fantastic. I think what we have is the ability to be creative and move more quickly than the college can on some of this stuff, hence why we were able to produce tools addressing all of this stuff during the pandemic, not waiting for time afterwards, which is how long it takes for the college to do things. So at the moment, we're really lucky that the college is on board with all of this stuff, but we see our role as pushing the college in the direction we want it to move in, and that's what all of you should be doing. That's why we have a college. Every single member, even though you might not feel very powerful, actually you can, through taking action on things like this and working with us in WHAM, can push the college in the direction we want it to go.
Thank you. Are there any other questions from anyone else watching? If there's no other questions, maybe I'll just finish with one final question, something that would be helpful for all of us here, sitting here in Evelina, whether we're in the community or whether we're in tertiary subspecialties or in A&E. What's the first thing we can do from this afternoon's clinic or today's next consult in terms of the toolkit we can have on a day-to-day basis to make sure that we're closing this gap?
Well, I'm just going to say it again, please sign up to show up. But other than that, if you go to the WHAM website, sign up actually if you're interested. And I say that because WHAM, one of the things that we do in WHAM is we provide a community of like-minded people, because doing this work is hard. It actually takes a lot out of you if you're doing your normal day job and you're thinking about this stuff in addition. And the nice thing about our group is that we are very supportive, we are very collaborative, but we can share, like the whole point of WHAM is that we share ideas, right? And so if I've had a thought about what I might do in my clinic, someone else can know about it in the rest of the country very quickly. In terms of what you can do, the WHAM website has a range of tools, the 1-minute tool and the 5-minute tool, which is all very quick and easy that anyone can pick up and literally do in their next consultation. And it will take you through how to do it. There's a little short video, there's like a script so that you can read. So you don't even have to like make it up yourself. Because some of this stuff is hard, right? Talking about poverty, talking about deprivation, it doesn't sit comfortably with us. But there's no reason that once you've tried that a couple of times, you can't be doing it. I would say if you are a total beginner and you've never done it before, go to that page, find the 1-minute tool or the 5-minute tool and just start playing with this stuff. You will start realizing that actually you could do it way better than what we've said, and you're going to innovate your own method of doing it and make it your own. But the more you do it, the more comfortable you feel. I'll tell you now, your patients will start having a completely transformative experience in your clinics, and you will start learning much more about what's going on in their lives and what's actually impacting their ability to be healthy. The relationships I've built since being honest about this stuff with my patients are they're transformational, and it's different. It's a completely different kind of medicine. So it's absolutely worth it for you, even on a selfish level, to try and change your practice. So yeah, just go to that element of the WHAM website. Alicia, is there anything that you would say as a junior doctor that might be useful? I think you're on mute. Oh.
Oh, that's a really good question. I think I definitely loved finding out about WHAM and stuff. I've now started incorporating it in my like when I'm clerking in A&E. And I think that has been really helpful in identifying like other needs that my patients have that could be contributing to like the biomedical reason why they're there, and thinking about the next steps of how we can address that. So yeah, I definitely recommend looking at the WHAM website in terms of what you can do realistically, like tomorrow or today even.
And actually, Nabil, at some point there was some interest in nephrology for actually implementing some of our like questionnaires and tools. I don't know if it was you, it might have been you, it might have been someone else, but they had actually said that they wanted to introduce it into the outpatient clinic in nephrology. But that's another thing, right? If as a healthcare system you decide actually you want to try some of this stuff in your outpatient or inpatient setting, we can help you. We've got some of that learning, we've got that institutional learning. We're so happy to help people to try and put this into place. And it is happening. It's spreading across the country in different hospitals. Like, be part of that movement. Why not see what you can do locally? So we're trying to make it as easy as possible, but I'm not going to pretend that this is like easy. But that's why if we join together, I think that it feels much more fun and much more manageable.
No, thank you. No, it wasn't myself, but I can see how it would help nephrology because you can really see that widening gap really does impact the outcomes of these patients who have these chronic conditions which don't have a cure.
Yeah.
And they have to live with chronic disease. But yeah, thank you so much, Goody and Alicia. Really, really interesting and inspiring work. And thank you for joining our Grand Round.
Yeah, no, thank you.
It's all recorded. There will be people that will watch it. So I imagine if anyone wants to contact you, they can do that through the WHAM website if they want to ask.
Yeah, or you can contact me. Oh, like I can put my email address if you want into the chat box.
Yeah.
I'm really happy to be contacted at any time in any way, on Twitter, whatever. But honestly, the important thing is that I think I would have been delighted if when I was at the Evelina, if something like this had been available, because I think there's something about being able to take action in the place you work, which is just really, really satisfying. And imagine being able to speak to commissioners, because there will be commissioners in that audience. And if you actually help to shape how the next services are put into place and what young people receive in the future, I mean, that's so empowering. So yeah, that's the kind of change that we're looking to institute and we want you to be part of. So yeah, get in touch.
Thanks very much. Everyone get their dancing shoes out. Brilliant. Right. Again, thank you. Have a nice afternoon.
Thanks for the opportunity. Thanks everyone. And thanks for listening.
Thank you very much, everyone. Thank you. Bye.
Bye-bye.